Well, it is wonderful to be here. Nice to see everyone. I think this is one of the first Zoom lectures I've attended where everyone has their video feed on. I'll never get to see anyone, so I'm usually just staring at like a blank screen effectively and talking into the ether and hoping that maybe someone's listening, but can never be quite sure. And then something will pop up on the chat and you'll be like, oh, we are live. Fantastic. Okay, so
just a quick heads up. So we are webinar formatted. So I don't know if you've used Zoom webinars before, but the attendees can't speak automatically. So if they have a question, they raise their hand or they put something in the Q&A.
Fantastic.
Down below or chat.
Great.
But if you want us to allow them to speak, just give us a heads up, and Cyan will be keeping an eye, and then we'll make sure that they're activated.
All right, I will continue to monitor the chat, so you can either raise your hand or if you want to type something in the chat, I will address any points that arise as we go along. And I encourage you to submit any questions or comments you might have, both as we go along and at the end. So without further ado, let me attempt to share my screen so I can go into the presentation here. Just give me a second. All right, can everyone see what looks like a PowerPoint setup array? Just type in the chat.
Yes.
Fantastic, okay, great. So let me set slideshow here.
It should be right bottom corner.
There we go. All right, fantastic. All right. So as Michael indicated, today I'm going to be talking about geriatric health services, both current arrangements and opportunities for reform. And I think, you know, anyone who is in any way involved in geriatrics knows that there is always the opportunity for reform. And I think that it would not be controversial at all to say that that is truly the case when it comes to pretty much our entire healthcare system. I always try to remember to use air quotes when I say system within the context of American healthcare. Of course, we mainly have a collection of arrangements that over time have come to add up to something larger than the sum of their parts. But whether we're actually getting to a system is open to debate, and that may be another topic for another day. But certainly my own view is that there are many elements, at least, that are asystematic. So I apologize if some of this is review for some of you. Hopefully you'll learn, everyone will learn a thing or two. A fun fact, at least, I like to throw those in so that even if you feel like you know the terrain pretty well, you can say, you know, I learned something during the course of that hour. Even if it's something as pedestrian as a fortnight is simply another word for 2 weeks. So there you go. You've learned something, hopefully. All right. So let me proceed.
I thought it was a video game.
Yeah, it is also a video game. Yes, absolutely. A wildly popular video game. That maybe once in this lifetime I'll have a chance to check out. Fantastic. Okay, so let's start with the elephants in the policy room, as I have entitled this, Medicare and Medicaid. And again, I know some of this is going to be a review, but I think it's worth revisiting nonetheless, okay? Hopefully it is no secret that Medicare Part A largely covers hospital or acute care. Medicare Part B is the part of the program that generally covers doctor's visits and quite a bit of preventive care as well. You may or may not be as familiar with Medicare Part C, which is more popularly known as Medicare Advantage. Medicare Part C is a portion of the program that has been growing incrementally since about the 1980s or thereabouts. It was officially christened as such, Medicare Part C, in the mid to late 90s, and took on added significance with later legislation. So over time, Medicare Part C has become a larger presence within the overall program. So Medicare Part C is that part of Medicaid in which the benefits are delivered through private insurers, although those private insurers are still funded by the federal government. So the funding still comes from Uncle Sam, still comes from Washington, but the benefits themselves are packaged, designed, and very much marketed by private insurers. It started small, so during the 90s, this was a very residual part of Medicare, and it has grown significantly, particularly in recent years, to a point where at least about a third of the program is comprised of Medicare Part C, and latest indications are that it continues to grow, possibly even beyond that. There's a whole interesting backstory concerning Medicare Part C. It used to very much be seen by many as more of a Republican project, but today it has fairly wide bipartisan support. Now, whether it functions perfectly well and whether it gives us the most bang for our buck in terms of taxpayers is another question altogether. But nonetheless, it has both grown in terms of its overall footprint within Medicare at large, and it has also grown in terms of the scope of its overall support as well, now largely bipartisan, with maybe a few dissenters here and there. Moving on to Medicare Part D, I always like to say, and it's really mainly true, the D stands for drugs. We're talking prescription drugs. So Medicare Part D is the program that covers drugs. Now, many Medicare Advantage plans come seamlessly with a prescription drug add-on, and that's one of the advantages, so to speak, of Medicare Advantage. Otherwise, those who stick with traditional Medicare have to go outside of the program effectively and find a prescription drug plan that is also run by private insurers as well. So that's a very important consideration when it comes to Medicare Part D. Medicare, of course, and we're going to cover this a little more fundamentally in a bit, but Medicare doesn't cover close to everything, of course. There are huge gaps in its coverage. It's the whole reason that there is an entire Medigap industry, so to speak, and many of the gaps, or seeming gaps, apparent gaps, if you will, also get covered by Medicaid, of course. And Medicaid has a particularly large footprint when it comes to long-term nursing care. So both Medicare and Medicaid are, of course, very large players when it comes to geriatric health services. Again, it's something of an irony that when we talk about senior health, you know, healthcare for those over the age of 65, the first word that comes to mind for many when it comes to policy significance is Medicare. But we're truly doing the actual policy landscape a disservice if we don't think also quite carefully about where Medicaid fits in. And in a bit, I'll show you about just how big of a presence within Medicaid overall senior health has. So let's move right on. So why do we see this level of programmatic fragmentation? Does it make sense to have these different parts? And how did we come about these different parts? Well, pictured here, and I have included this picture quite deliberately, is on the left, then President Lyndon Johnson, and on the right, then former President Harry S. Truman. They're brandishing proudly the souvenir signing pens that he received in association with the signing of Medicare and Medicaid. Both were passed as a single package in 1965. However, that end game really doesn't describe accurately the fragmentation that we saw leading up to the passage of both of these programs. And in fact, Medicare, what became Medicare Parts A and Part B themselves were previously independent, separate pieces of legislation. Medicaid was actually another policy alternative. So Medicare Parts A and B, separate pieces of legislation, and then Medicaid, another piece of legislation altogether. And it's an interesting pedigree because Medicare Part A was the original Democratic progressive bill that was offered as MEDICARE. So the bill covering hospital benefits. Again, Part A was always designed as a compulsory program that everyone was required to pay into, and very much a universalist program. You get it, everyone gets it after the age of 65, regardless of how much you paid in over time, but everyone is required to pay into it, and everyone then receives the benefits statutorily. So that was always Part A. And it had been offered up by various Democratic figures in Congress for the better part of 10 years by the time of passage in 1965. That in itself was the result of an evolution that occurred even before that. So MEDICARE effectively was the representing the narrowing of vision that occurred on the part of, again, these progressive sorts, both within Congress and elsewhere, who had spent the better part of 40 to 50 years fighting for universal health insurance, preferably universal health insurance in which the benefits would be funded by the federal government, largely the federal government. So the idea initially was to cover everyone. And this was something that, again, progressives of various stripes fought for all the way from the 1910s up to the early 1950s or thereabouts. After a succession of defeats, which largely came at the hands of, probably guessed it, the American Medical Association, some other sources, small business groups, etc. These same reformers decided to change tack and to narrow their vision and to focus on groups that many people could agree were in some form or fashion deserving, particularly deserving of benefits. So initially the idea was, well, those over the age of 65 certainly qualify in that regard. After all, pre-Medicare, to be over the age of 65 in many cases meant to find yourself in poverty. Now, why was that? Because we really didn't have private retiree health benefits to speak of. Most employers were not offering continuing coverage for employees beyond the age of 65. Private insurers, for their part, were not eager to sign on those over the age of 65. After all, this community is almost a sure bet for almost immediate claims. So the risk was thought to be too great to take on. Therefore, private insurers were effectively blocking out those over the age of 65. And again, there wasn't really an employer plan to cover former employees, retirees, etc. So many seniors ended up having to pay for healthcare almost entirely out of pocket, or were reliant on family funds or various programs of charity care. And so many people who had parents, grandparents, knew quite well how high the stakes happened to be. And therefore, it was agreed widely that those over the age of 65 were ripe for some form of government coverage, especially given the fact that the private sector was not eager to provide those benefits really in any form on its own. So without that sort of competition, if you will, and without an employer-based system that would cover retirees, reformers decided, okay, let's focus on this population individually, okay? Now, there was still opposition from groups like the American Medical Association. The American Medical Association was so opposed to it that they came up with their own program known as Operation Coffee Cup, okay? The idea here was doctors' spouses, actually, would convene groups of their friends around, you guessed it, cups of coffee. I even brought my own souvenir cup here. Actually, this has coffee in it. I'm probably going to take a sip soon. And they would thereby talk up the dangers, the inherent dangers of socialized medicine, the creep of socialized medicine, quote unquote, in the form of Medicare. So the opposition was great. And by the way, the face of this campaign that they offered up in the early 60s was a B-movie actor who would have been recognizable to many by the name of Ronald Reagan. You too may have heard of him. in another, in connection with his later exploits. So there's still quite a bit of opposition, even for this narrowed vision, so to speak. And therefore, those who were opposed to the vision for Medicare that was being offered, again, hospital benefits, compulsory program, quickly came up with alternatives that they found to be in some way less objectionable, so to speak. So one of these alternatives was a voluntary program. Let's not go the compulsory route. Let's make it voluntary. So a voluntary program, largely to cover physician visits, okay? So that was one of the alternatives that was offered up. The other alternative followed off of a pre-existing program that was a grant program to states to offer health benefits to poorer citizens. And I think you can see the framework is in place for what would become Medicare Part B and Medicaid, respectively. These were offered up as alternatives from groups of other conservative Democrats, Republicans, etc. And the genius here, the domestic political genius here of President Johnson, again, seen on the left, was to put them all together, combine them all into a single package, and to pass them all and to say, well, let's all take credit for this. Let's spread around the credit. And that was one of the largest ways that he was able to come up with this landmark success in 1965. But again, the fragmentation that was present at the creation is in many ways still with us. So that's why we have these various parts of Medicare, why they look so different in many ways, and in fact, why we have even shunted the important function of long-term nursing care onto an entirely different program altogether, and that is Medicaid. It all goes back to this founding moment and arguably what came before this founding moment, effectively in 1965. So again, I'm not going to dwell upon this too much, but Medicare represented this narrowing of vision from what was originally a drive for universal coverage. And by the way, those who put forward Medicare and Medicaid were very open about the idea that, okay, this is a good start, but we'd really like to see this expand eventually to cover everyone. And so from a very early point, there was the idea that Medicare would effectively morph into Medicare for more, if not at some later date, Medicare for all. So now when we've entered a period in which, at least for a moment, Medicare for all seemed to be potentially back on the table, this is really a return to the situation that was present in the 1960s when the program first was created. This idea of expanding it steadily to cover more people, of not simply having it stop at seniors, was really always a part of that political moment. And therefore, this is nothing new, but more of a return to what we saw some 50 to 60 years ago. So Medicare, as we said, does not cover, for the most part, long-term care, particularly long-term nursing care. However, there are a few exceptions that I did want to mention. Medicare can, under some circumstances, cover certain episodes of ongoing or long-term care that is designed to arrest the decline that goes with a potentially terminal condition. And it does cover at least certain hospice care as well, again, toward the end of life, though there are serious boundaries and parameters as to what is covered. So there are certain exceptions to this rule that Medicare does not cover long-term care. And these are a few of the exceptions. It is very complicated. But for the most part, when it comes to long-term nursing care particularly, the program of interest and the program to watch, therefore, whether you are entering this from the perspective of a practitioner or a patient yourself, or perhaps the son, daughter, grandson, granddaughter of someone who finds themselves in need of long-term care, the program you're looking toward really, in large part, is going to be Medicaid, again, with a few exceptions here and there. Even outside of, again, long-term care, Medicare doesn't cover everything. I've talked about the gaps. Here are a few, just a few of the gaps. There are others, including quite important areas like dental care and eye exams. Now, many people who are on Medicare choose to combine it with some form of what's called Medigap coverage, and Medigap is often a very profitable line for insurers as well. So this sits alongside traditional Medicare coverage. So even outside of long-term care, there are also other exceptions, other gaps in the program. And by the way, that's why if we were, in fact, to look toward some form of Medicare for all, so to speak, we would have to be very clear of just what that looks like. Because I think many people, outside of, again, the geriatric community, probably assumes that Medicare covers most healthcare that seniors would need. That is very much not the case. So if we're talking about expanding Medicare to everyone, just what are we talking about? Are we talking about expanding the current traditional Medicare that doesn't cover quite a bit, actually, contains quite a few gaps? Or are we talking about making Medicare more comprehensive and then expanding it to cover other age groups? This is a debate, a discussion that we're going to have, and that we may have, depending again on how the politics play out in the next several years and decades. So again, something significant about Medicare that may not be known to the larger public, but of course is clear to those in geriatric care. So those are just some areas that Medicare does cover. There are, again, others. Now, moving over to Medicaid, I mentioned that seniors have a very large footprint, actually, within Medicaid generally. And you can see that a bit here. So overall, Medicaid is a very large program, similar to Medicare. When it comes to, by the way, how much the country spends overall on Medicaid versus Medicare, the country spends a little bit more on Medicaid, but it is, not significantly greater, actually. And the biggest difference between Medicare and Medicaid in terms of the way that they're structured, of course, is that whereas Medicare is a federal program administered by the federal government with relatively little input from states, Medicaid is very much a shared state-federal program. It is funded by both the states and the federal government. That's the funding burden is shared between the two. And in terms of design, the states have quite a bit of leeway in terms of, in many cases, services that are eligible for reimbursement. And again, just in some cases, who is eligible as well, based on income and other considerations. So Medicaid, as many of you probably know already, looks dramatically different depending on which state you happen to find yourself in. So you have certain states like New York that have fairly, I'm going to call them generous Medicaid programs in terms of what is covered and who is covered. But you have many other states in which the eligibility criteria is set extremely low, and the range of services covered is considerably narrower as well. By the way, if you're interested in further reading, there's an outstanding book on the differences in eligibility and services covered within Medicaid called Fragmented Democracy by Jamila Mishner. It's a fantastic book, a lot of great detail there. So looking at the program overall, the Medicaid overall, this is how it breaks down in terms of the different groups that are covered. You can see that children numerically form a fairly large part of the population that is addressed through Medicaid, with adults under the age of 65 making a smaller part of that programmatic footprint. Initially, seniors look like a fairly small part of the overall equation. at 9%. But you can see that when it comes to how much money the program actually spends, that 9% increases all the way up to 21%. So you're talking about nearly a quarter of Medicaid spending going toward seniors. And another large portion, in fact, the largest share of funding going toward those with disabilities, although, again, numerically, those make up only about 15% of the some 68 million enrollees nationwide. So this gives you a sense of how big that footprint is when it comes to senior healthcare out of Medicaid. So I don't think it's any secret that Medicaid is a major player when it comes to senior care, but this gives you a sense of just how much within Medicaid senior healthcare comprises. Now, Medicaid eligibility has historically been based on several considerations. I mentioned income eligibility. So this is a bit of a complex tale. I'm not going to go into every single detail, thank goodness. You can tell already that I'm someone who likes to go into the history and the political weeds. I will do my best to avoid that temptation here. So when it comes to income, initially, the Affordable Care Act, as you may have heard, set an income eligibility limit at about 138% of the federal poverty line. And this would have held nationwide, okay? This was significant because, again, I mentioned that some states set very low eligibility limits. In some states, particularly in the Deep South, that eligibility limit is closer to, say, around 25 to 50% of the federal poverty line. So imagine hiking that all the way up to 138%. That's a significant rise, needless to say. However, the Supreme Court came in 2012, had its say when it came to the Affordable Care Act generally, and decided that the way the law was written, that is, it conditioned the continued reception of federal Medicaid benefits on expanding the program. So those states that failed to expand the program would lose their federal share of Medicaid funding. And that was ruled to be coercive. So the Supreme Court ruled it's coercive. You can keep the Medicaid expansion, say that states must go up to 138%, but you can't attach that penalty to it. So what happened? Well, overnight, the Medicaid expansion became purely voluntary. And that was a major shift, obviously. This is still about having a sufficiently low enough income or amount in liquid assets before one becomes eligible. I said there were some other considerations because there are certain categorical populations that are also expressly included or have been historically included, including certain expectant mothers, etc. But when it comes to income, again, income is the major story when it comes to Medicaid. You become eligible, for the most part, for Medicaid once your income reaches a certain low enough level. So some are eligible when they reach the age of 65, when they need long-term nursing care even. This is usually in today's society much later, actually. But some by that point are down to the level in which they become eligible anyway. So that describes some individuals right off the bat, in which case, you know, they become eligible for Medicaid and Medicaid begins paying for long-term nursing care. However, others must spend down their assets until they get to a minimum level. And another consideration that comes into play is if you have, say, one spouse who is going into long-term care while the other spouse is outside. There is some consideration for that as well in terms of the amount that is allowed to be held. But many people try to plan ahead for this outcome through gifts and transfers in some cases. However, any gifts and transfers are in many cases subject to a so-called look-back period. And if gifts and transfers are made within a short period of time before eligibility, that can then accrue penalties, which are, and so it's important when planning ahead for this eventuality to do so with a sufficiently long time frame so that the spend down or the transfer of any assets in order to get to eligibility is planned carefully so that the penalties are at a minimum. They may not be avoided in all cases, but at least they are at a minimum. And again, all of this is because Medicaid, again, eligibility is tied largely to income. I mentioned before that the entire reason initially that the idea of health benefits for seniors was explored was because seniority and poverty were nearly synonymous pre-1965. Today, that is much less the case. Of course, it's the case for some, for still too many individuals, but it is much less the case. However, that policy legacy remains, this consideration, this idea that seniors are those who have very little in the way of funding available, and therefore it's still tied to income eligibility. I tried, I'm going to continue this quest to find out definitively, and I'm sure it's something that we can explore more in future, but definitively why, beyond the cost, the sheer cost involved, why long-term care got left off of Medicare and ended up under Medicaid. Again, my guesses would be considerations of cost. There's a very large cost involved there. But also potentially, again, the policy legacy of the programs that came before Medicare and Medicaid. And my guess would be that before that, states and localities were largely the ones involved in funding this sort of care. And therefore, when Medicaid kind of was passed the baton in terms of continuing those programs, long-term care simply continued to fall under the responsibility of this program that, again, is largely the purview of the states, although the federal government has a loud voice when it comes to funding and when it comes to setting certain very minimal benchmarks as to what states, absolutely must cover or can cover. In effect. So that would be my guess, something I want to look into a bit more, but some of you may already know or have an idea as well, and we can talk about that certainly. Of course, there is quite a bit in addition to professional caregiving in long-term care facilities that goes on. There's quite a bit of unpaid caregiving, and I wanted to show you some of the numbers involved in that. It is thought, and again, these are estimates, they're inexact by their very nature, but potentially the value of free, uncompensated care may come to as high as $300 billion a year. And of course, caring for older relatives particularly has real consequences when it comes to keeping people, historically it's largely been women, out of the workforce, at least on a temporary basis. So we see here that women have averaged historically over 11 years out of the paid labor force as a result, with men, again, coming in far behind at 1.3. That gets into a whole other discussion of gender parity, which again is part of this as well. And it is thought because workers are also those who have to take time off to provide care, that businesses indirectly may lose up to nearly $30 billion a year, again, because of that need to care for loved ones. And the reason, we have so much uncompensated caregiving when it comes to seniors is because of, well, it's several reasons, but I think one of the reasons that looms large is the insufficiency of arrangements that we have. And the fact that we rely on Medicaid for a significant part of long-term care, particularly, but Medicaid can't do everything. Medicaid benefits are relatively low. Again, becoming qualified for Medicaid can be challenging itself. Reimbursements that come out of Medicaid are very low. In fact, generally when compared to Medicare and private insurers, certainly they're really at the bottom of the barrel in most cases. Really the chronic underpayment on behalf of Medicaid is an issue for many providers. Some of you have probably already encountered this. And so for a variety of reasons, Medicaid on its own is really insufficient. So we see a lot of caregiving that goes largely uncompensated for a variety of reasons. And I see we have various stakeholders in Medicare and Medicaid that shape politically long-term care. Absolutely. That's right. Okay, great. Yeah, if you can send me those, that'd be great, because I'm still, of course, sort of grappling with that issue. So thank you very much. So obviously, there's a lot of uncompensated care on top of what Medicaid pays for, effectively, and this is a huge burden for family members once seniors reach that age where they can really no longer live independently and require particularly round-the-clock care. It's, again, it's a challenge, a conundrum that has been faced, I think, by, we all know people, right? And in some cases, they describe ourselves, right, in terms of this phenomenon. So it's widespread. All right. So I have okay, there we go. Now, we live in a federalist system, as my discussion of Medicaid has made clear. And what that means is that all levels of government, local, state, and federal, are involved in most domains of policy. And health policy is no exception to this rule. So when we look to what various governments are doing, we need not just look at Washington, look toward Washington, but also look to the states. So we are here, of course, in New York State, or most of you are probably in New York State right now. We're all coming from various places. And there are several programs that are fairly unique to New York State, although some states have some similar programs that have begun to branch out a bit in the way that Medicaid and other funds are used, and to try to hopefully get toward better, more equitable outcomes. One of these programs is the Expanded In-Home Services for the Elderly program, which funds at least some care in home settings as long as possible, with the goal of avoiding more expensive Medicaid-funded care in long-term nursing facilities. So long-term nursing facilities are some of the more expensive venues in which to provide care. If at least some of that care can be provided in the home setting, the idea at least is that in most cases, that care should not only be more reassuring to the patient, the family, etc., but could in fact lead to some cost savings. And if you're a bean counter, if you're an accountant, if you're someone up in Albany, that's really what counts at the end of the day. So the idea was that if we can keep care in the home venue as long as possible, then we'll save Medicaid money, and the state will spend less. So these phenomena have been around for a while in various forms, but they got beefed up in 2011 with the advent of the Consumer-Directed Personal Assistance Program, which allowed for more training and funding of family members to assist with care. So people could select family members to help with that care, which was a novel development. And again, at the beginning, the goal was twofold: quality of life, improved quality of life for those in that stage of life and care, but also hopefully to lead to certain cost savings, certain efficiencies. Now, there's a certain irony in the latter, because while this program, I think safe to say, has probably led to, yes, some improvement in terms of quality of life, in terms of cost saving, it was much more disappointing. And so 2011 was the year when the governor convened what was known as the Medicaid redesign team. Some of you may be familiar with that chapter in the state's recent political history. And one of the programs that came out of it, again, was CDPAP. Recently, on the very day that New York City recorded its first COVID case, by the way, the second Medicaid redesign team, MRT2, reported out its findings and initially sought cuts in these programs. Because it thought that not only did they not generate savings, but it was thought that they were ballooning the overall cost of Medicaid. And there were various arguments still going back and forth as to why that's the case. Is it the case that the program was just poorly conceived to begin with? Is it the case that there were abuses, there was fraud in some of the arrangements that developed, and therefore it's not really the fault of the policy designers per se? Again, that's something that is very much being debated. But these programs' funding was on the line, and in the event, the funding was cut at least somewhat, in some cases quite substantially. However, there's an epilogue here because those cuts and most of the cuts that were sought by MRT2 are now on hold. And the reason for that is that the various aid packages that initially went to the states had as caveats, if you will, attached to them that states were not allowed to play around with eligibility, program eligibility, and make significant changes in their Medicaid programs if they were accepting this emergency funding. So New York State accepted the emergency funding several times over, and as a result had to agree to at least put on hold, as long as they were receiving funds, these initial cuts. Now, these cuts could still come to pass. So it is still unclear what the precise future of these programs here in New York are going to be in New York and elsewhere, really. But the cuts have at least been delayed. And again, that is as a result of the emergency funding packages that were accepted by New York. The governor, by the way, was absolutely incensed when he learned about this. MRT2 was very much, the Medicaid redesign team 2 was very much his creation. He was hoping to take some major cuts out of Medicaid. And he effectively balled out, if you will, the New York congressional delegation for failing to get authorization for New York to be able to move ahead with these cuts at the end of the day. But again, unsuccessful in that regard, and therefore they are delayed at least at the present time as a result of New York's acceptance of the emergency funding, again, over several tranches now. So that is about the end of my prepared remarks, but I'm happy to take any questions, comments you may have.